immediately regretted the title, as I've chatted to Carol about, because I realized I had bitten off way more than I could chew to try and summarize over 15-20 minutes the clinical research landscape for dementia. But however, I think what I'll try to do in this morning's presentation is give a sense of the opportunities that are there to both scientists and clinicians who maybe aren't working immediately in around memory services or clinical services for people who are working with, and maybe give them a sense as to how they can link in with services that may be close to home, or indeed with services elsewhere in Ireland, to explore some of those questions that they might have. As Carol mentioned, I'm a geriatrician based in Cala Hospital. I also work in an integrated care post, so also out in the community. And as such, what we've tried to develop is an integrated care model for people with dementia, from the acute hospital diagnostic piece right through to supporting people with advancing symptoms in the community. The first place to start is really, what do we mean by clinical research? And the simple answer is that it's research where people, data, or samples of tissue from people are studied to understand health and disease. And its purpose is to help us find new and better ways to detect and diagnose, treat, and prevent disease. The more complex, if you like, version of that breaks that down into, well, what exactly are the components? And I think most people who are interested in research in dementia will identify with more than one of these, but it's, whether you're looking at either, diagnostic clinical materials, interactions with patients, data, or different populations. It's about trying to understand disease mechanisms. Sometimes it's translational, so trying to take, concepts into clinical practice, enhancing our knowledge, looking at therapeutic interventions, both, maybe pharmaceutical and non-pharmaceutical, in particular with regards to dementia, how we can incorporate prevention, especially in light of the now quite overwhelming and significant research that's suggests about the potential to prevent dementia, behavioral research with regards even some of those prevention mechanisms, but also maybe research that helps manage behaviors that can happen in advanced stages of dementia, and health services research, epidemiology, and community-based and managed care-based studies. So you can see, when we talk about dementia, we really are talking about the full gambit, really from midlife right through to later life. So there's huge amounts of opportunity. It's very much a continuum of research opportunities, as opposed to just a discrete entity that affects a small group of people. I'm not going to go into many will be aware that we have at least 55,000 people who are living with dementia. I think there's at least 100,000 people who are at risk of cognitive decline who are undiagnosed, and within Ireland, and there's probably 100, there's up to 500,000 people who are supporting the care of people who are living with either dementia or cognitive decline. So dementia and the need to support people living with dementia, and the need to come up with solutions for dementia, is very prevalent across our Irish society. And as important as it is within the context of a developed country like Ireland, the real pressure point for dementia and developing dementia services is going to be in lower middle income countries, where they've had this large increase in their aging populations. And it is beholden on us, some of us in the developed countries, to try and identify solutions that will help them manage this, this experience, which is for many countries the first time that they're actually trying to develop care systems for large numbers of people who are living with dementia. So there is that symmetry between what we can do to help our global partners as well. To bring it back down a little bit more local, though, is when we talk about clinical services in Ireland, well, there is a difference right across the world about who are the clinicians most involved in dementia diagnosis, and in particular, I suppose, in around memory services. In Ireland, I suspect about 80 to 90% of most dementia services, our memory clinics, are geriatrician-led, probably 80%, and then the rest psychiatry or later life psychiatry and neurology. There has been this very welcome increase in the amount of nursing roles, in particular advanced nurse practitioners and clinical nurse specialists working in memory services over the last few years. And of course, we're also growing that base for allied healthcare professionals, neuropsychologists, occupational therapists, speech and language therapists, and social workers, who are also becoming who are becoming more prominent in our delivery of clinical services. But that's very much the, I suppose, the memory clinic and hospital-based models. Of course, there are huge numbers of partners involved in the delivery of clinical services, from our formal health services, private hospitals, the National Dementia Office, DIDC, and I'm sure as soon as you do a slide like this, you're probably going to be guilty of leaving out people, but also then our voluntary services and corporate services, who really provide care for people with dementia right across that life continuum. And this was work done by the DSIDC, who were looking at the memory services across Ireland. And when we look at memory services, we can see that there is an equity in the distribution and the spatial distribution of memory clinics across Ireland. And that is something that I know the National Dementia Office are working to address. And also what we understand by what memory clinics do is quite heterogeneous, and there's diverse models and practice, and different clinicians will have different focuses in how they do it. So there is a greater need to standardize in some respects what it is we deliver through memory clinics. And that's why I'm going to largely talk a little bit about our own experience here in Tala, because I suppose there is a difference, and there are different models across. All have pros and cons, as with all of these things. I think it's about kind of trying to reach out to your local services, see what it is their model is, and see how it's possible to link in with it. And then, in around then this model, we have certainly got, when we look at the assets available to us, and this is a GRNI slide, we have quite a few assets on research assets. And in fact, we've got a better probably geographic spread on the research assets to support researchers who are looking to engage in dementia than we have maybe the clinical services to plug into. So some of the work that Carol and others in DRNI are trying to do is trying to make it easier for people who may not be clinically based or based clinically close to dementia services to be able to interact and translate their research interests into clinical environments. I'm very much, that it's like that old saying, if you only have a hammer, you'll only ever see nails as problems. Needless to say, when I was trying to think of how best to present these opportunities and challenges, I kind of folded back into what I'm most familiar with, which is the clinical scenarios. This is very much a simulated case, and it's based on, but very reflective of what we would see routinely here in our memory service. A 60-year-old female referred to the clinic by her GP, had a mini mental score of 29, so pretty good. Subjectively, she was reporting short-term memory problems for 6 months to a year, forgetting names, forgetting what she had gone to the shops for, repetitive in conversations, but actually was still working and ran her own business. She had a brief memory screener, which showed, this is a Montreal cognitive assessment, which many will be familiar with, and she scored 24 out of 30, and the main issue was with regards her delayed recall. Very little with regards to medical background, but did have a family history of Alzheimer's disease, and her mum had Alzheimer's disease in her 60s. Husband, most important part of the clinical workup is, that informant history, and her husband had identified short-term memory issues, noticed that she'd become more repetitive, but yet again, no evidence of any functional loss. And I suppose for those not necessarily working in memory clinically, functional loss, while we talk about memory as though the key thing, the most important thing I'm always looking for in a clinical scenario is with regard to somebody's function. That is the differentiator between somebody who has a memory nuisance versus somebody who has a memory problem or dementia. So the fact that this lady was functionally independent still was quite reassuring, and her other tests were normal. Give an example of a memory service. What we do here in Tala is there's a centralized reception for all of these referrals, and we kind of stream these referrals with regards to memory. So those people who are over 65 who have clear evidence of either functional decline or a decline in objective scores will often come into our general geriatric medicine clinic, and they'll be assessed initially there, and if necessary they'll be referred onwards to to one of the other services. For people who we get a rapid, we get an urgent referral on. So let's say people who have behavioral or psychological symptoms, or would have been involved with us beforehand, we would bring them into our day unit, or our integrated care team would go out and visit them at home. And this is largely for those people who probably couldn't, wouldn't, or shouldn't come to hospital, in the context of their symptoms. And then stream 3 is into the specialist memory assessment service, and this would be, we would take referrals from around the country, people over the age of 40 with atypical features, and try and bring them into a more, if you like, where they would get more detailed workup. Having come through that system then, and I'll talk what's involved in that, they'd come into the post-diagnostic supports, which involves being seen in our brain health clinic, or the carers education and support group, or specific post-diagnostic clinic where we go through different diagnoses and things like that. And I just put this up as a reminder, just that, in the last few months, we've also established the National Intellectual Disability Memory Service, along with Mary McCarran and colleagues from the Daughters of Charity, which has been very successful as well. With regards then to people who come into the, and we have about 250 new referrals per year of people who come into the pathway to have a more enhanced kind of cognitive workup. They will get a detailed neuropsychological assessment, also assessment for anxiety, depression. We'll look for delirium. We'll look for other any evidence of other if you like psychological factors that may be contributing to the memory. But it's grown out of a gerontology service. So while we take all ages from 40 onwards, we actually also apply those gerontological principles. So we do look at how they walk, we look at their nutrition status, we look for frailty, we look at vision and hearing. And then the occupational therapists would perform a assessment of motor and process skills tasks to look at functional, objectively to look at functional ability. And then our speech and language therapists would be doing cognitive linguistics assessments. In the memory service, there's consultants, 2 A&Ps, neuropsychologists, speech and language therapists, and occupational therapists, and then we take in other input such as social worker, etc., as required. And the pathway then just kind of is there, outlines that the initial assessment is and the information is nurse-led, neuroimaging is booked, everybody gets discussed at a consensus meeting, and then depending on how we work through what the working diagnosis, then further assessments by the speech and language therapist, occupational therapist, or neuropsychologist, or if we wanted to do more advanced neuroimaging or something along those lines, in which case then, and after those things are done, they're back to an appointment with ourselves to do a disclosure and discussion about what we feel is the diagnosis. So to go back to the case as the spine of it, this lady would have had her MRI brain. It demonstrated that she had mild changes on her MRI, but it was largely unremarkable. And her working diagnosis, given that she's functionally independent, given that her neuropsych assessment demonstrated that she had amnestic symptoms that were 1 to 2 standard deviations out of kilter for age and education, was that she had mild cognitive impairment. And up until a few years ago, that's where we would have left it with this lady's diagnosis. I suppose since 2011, everybody has been working to incorporate then biomarkers into this diagnostic paradigm, and there was this breakdown of how we can look at those diagnoses in the context of biomarkers. I think the main, if you like, bracket that we look at is preclinical Alzheimer's disease, which are people who are cognitively normal. And today, to be honest, we would rarely see those people in our clinic. It really would only be in a research context that they would be in. Or prodromal Alzheimer's disease, which is what this lady has, where she has mild cognitive impairment and has biomarkers that are positive, or dementia due to Alzheimer's disease, which is what we were traditionally, the majority of people who would be seen in clinic, that's what they would have been diagnosed with. So this lady had CSF biomarkers, and her CSF biomarkers, where we measured levels of her amyloid and tau and phosphorylated tau, are able to give detect these Alzheimer's disease proteins. And I think that's the important thing, is this is a detection test rather than a diagnostic test. And, but we would revise the diagnosis to mild cognitive impairment due to these Alzheimer's disease proteins that have been detected in her CSF. The other these are images from one of the trials, one of the pharma studies that we would have done, but this will be clinically available from January of next year, is amyloid PET imaging, which is a specialized amyloid scan whereby we're able to get a sticky radioactive tracer. So the CSF studies are based on us doing invasive lumbar punctures. We would do them on all of our, or we would look to do them on all of our patients with mild cognitive impairment or subjective memory complaints or atypical symptoms. But it is an invasive procedure, and sometimes there are reasons why you can't do lumbar puncture. So somebody may have had a fused spine, they may have severe back pain, they may be on anticoagulation, so blood thinners, which stops us doing them. So there's about 20–25% of people who we won't be able to do CSF testing on that we would like to do it. And one of the alternatives, which is well established in a lot of other countries and will be available here clinically in January, is the amyloid PET scans, where you can radiologically measure and quantify the amount of amyloid in an individual's brain. And you can see here, these are two people who have mild cognitive impairment, but one of them, when we do the amyloid imaging, has very little amyloid within their brain, and the other one has quite a bit of amyloid. Where this is going to become a very important factor is as therapies emerge, which are primarily focused at the moment around reduction in amyloid. Well, obviously person B is the person you'd want to give that therapy to. It's not likely that person A is going to get any therapeutic benefit from it. We also use other, currently we use things like FDG PET for looking at metabolic activity in different regions of the brain. We look at DAT scans for identifying people with Parkinsonism. Of course, everybody coming through our service will get a CT or an MRI scan. So I think over the last few years, the big game changer has been these predictive markers that have helped us detect the risk for Alzheimer's disease much earlier in the time course. So if you take our CSF biomarkers up to 25 years before anybody has symptoms of dementia, those CSF biomarkers are present and causing and give a big window of opportunity for future therapies, hopefully. And that is the main hope that we have. Drop back then the clinical real world. This diagnostic process, if you like, which gets to what I would always classify as a working diagnosis, because time is the biggest diagnostic aid, and most of us working in memory services have frequently changed our mind on the diagnosis of an individual, seeing them from one year to the next and seeing how their symptoms have progressed or new symptoms that may have evolved over that year. But from the point of view of when the referral lands to myself to when I'm sitting in front of them giving them a definitive working diagnosis, it's typically 3 to 4 months. And that's because it takes time for the CSF markers to come back, time for imaging, time to do the neuropsych testing, and all of that has to be paced out. At the follow-up then from that disclosure piece, they will either go to our brain health clinic, so our patients with mild cognitive symptoms will go to the brain health clinic, which really focuses on interventions, if you like, a personal protection plan for brain health, where people will, it's individualized around the factors that we would have identified, that are whether somebody has diabetes, high cholesterol, high blood pressure, sleep difficulties, stress. The advanced nurse practitioners host this clinic and go through strategies with them to address some of those risks. Generally speaking, we'll repeat the neuropsych assessment annually for at least 3 years if their CSF was amyloid negative, or if we weren't able to do CSF, and 5 years if it was positive or we weren't able to obtain it. So just even look right now at this case in this lady's scenario, the research opportunities are, many sites in Ireland have done definitive intervention studies which have looked at medicines to try and reduce amyloid. There's a lot of research to be done in looking at better neuropsychological approaches and language evaluations, which may help address symptoms and also aid diagnosis. How can we also take then those neuropsych deficits and language deficits and turn them into therapies? How can we make this, it takes 3 to 4 months. Can we make this process faster? Can we make it more personalized? Can we look at other biomarkers, digital? Can we use this, artificial intelligence, machine learning to do this? Things like gait and speech, which are things that, some groups are looking at. And what's the best diagnosis disclosure process, because there is still quite a spectrum in how diagnosis is disclosed, and what does an accessible brain health or prevention program look like, because we're a long way from having, despite the fact that we know that 40% of dementia may be prevented, we have no adequate accessible prevention programs. We've very much tried to take an integrated model of care across this continuum, looking at different stages that we can support, and really looking at the same team and the same service supporting right across that continuum. In the interest of time, I'm going to kind of go through a little bit quicker. So if we take this lady, then her symptoms progressed, and she was diagnosed with dementia and commenced on medication, but had a fall at home and was hospitalized. Hospital being a very cognotoxic environment, there's lots of things as a result of the environment, medications, breaks in routine, and delirium. Oftentimes people, there's a lot of research, and I know certainly Dr. Timmins down in Cork has done a lot of research looking at the impact of hospitalization for people living with dementia, how we can improve that, how we can look at strategies to support hospital avoidance, diagnosing and managing delirium, and optimal rehabilitation in people living with dementia, because we still don't know what is the optimum rehabilitation program for people living with dementia, and some people will take a very nihilistic approach towards giving any rehabilitation to people living with dementia. So this lady recovers in hospital but hasn't recovered to her baseline, and she's discharged home. How best now, the research questions around this area is how best to support her living in her own home. Can we look at different models of clinical care, such as telemedicine, that don't have it necessary that she's having to come into hospital or even go to the GP? Can we support those clinical services to her home? How do we structure a home care package so that she gets the best benefit from it? Is there assistive technology and digital care that supports her living at home? And then also, what's the best means of doing the care education and training for the family or for the carers who are supporting her there then? And then I think there's a bigger question that that groups such as Trinity House and other groups around the country have looked at is, how do we develop resilient communities for people who are living with dementia? And certainly there has been projects that has looked at, let's say, for example, Kinsale, where you take a macro, meso, micro level towards, planning areas for, planning communities with the support needs of older people in mind, right down to the micro level where you're looking at what is the home environment that best enables independence. Invariably, about 1 in 5 to 1 in 3, 1 in 5 to 1 in 4 people with dementia will proceed, and at some stage may require an escalation in their care to a long-term care facility because they're unable to manage at home. And we still have to figure out, and I think COVID has very much exposed it, what's the best model of long-term care provision? How do we maintain, or what are the best care standards and life enhancement programs in long-term care, such as music and creativity? Is there digital care, such as robotics? So, colleagues in Galway and in Trinity have been looking at how robotics can support both social and communication engagement for people in long-term care facilities. And then if we bring it back to palliative care, how do we deliver, what is a holistic palliative care model for people living with dementia? And yet again, Dr. Timmins and her group have done quite a bit of work in this, looking at this in Cork and in people with Parkinson's in particular. So I think that in the context of 20 minutes to try and talk about this, I think it's about really laying out that clinical services in many places have very much evolved, and we are doing our clinical services here will stand up against clinical services in most other areas of the world. There is a bit of a postcode lottery around access to some of those enhanced services, and that's something that the National Dementia Office are certainly working on. But there's lots of opportunity for collaborative research across that full care continuum. I think clinicians are by and large busy people, so for people who are outside the clinical service, I think a very good first step is to engage about trying to come in and see what actually the service and what that experience of a diagnostic process looks like. I am always kind of, I do find it, one of the lost opportunities is that more scientists who are working with dementia don't actually take advantage of the opportunity to come in and actually see what it really looks like. That lived experience for people receiving diagnosis, and the lived experience for clinicians who are trying to deliver those services. Link with local services, and then if there's nothing locally, I think link with DRNI to get connected. So thank you very much.
That's great. Thanks very much, Sean. That was really interesting. Hope everyone else found that equally interesting. So we have one question anyway, there in the Q&A section. So a question about autoimmune dementia. Have you come across autoimmune dementia from time to time? And what does this mean for differential diagnosis, testing, etc.?
So I think, yeah, I mean, it's very rare. Yes, we do come across, autoimmune or immune-related dementia subtypes. It's primarily neurologists who would be dealing with it. I mean, there's where we would see things like a limbic encephalitis. I mean, it's a rapidly progressive dementia, and it's slightly atypical and wouldn't be very common. Is what I would say, and it would usually present in the context of somebody who may have had atypical behaviors, rapid cognitive decline over a matter of months, perhaps seizures as well, and then maybe associated with other medical issues that might be going on at the time. But it's certainly rare and often would present through an emergency department rather than through your traditional memory services, and would generally be neurologists who would be dealing with it.
Right. Okay. Thanks. Another question coming in is, how is COVID impacting research, access to patients, families and carers, etc.?
So there's no real short answer to that. I mean, I suppose what we have is we have our clinical services fully back up and running. So all of our support services and things like that are going back up and running. I mean, COVID has had a profound impact for people living with dementia just by virtue of the isolation. I think the anxiety with regards to it, and the fact that carers haven't been able to get access to the day centres and the other supports like respite care that they would usually be able to get to, has meant that has become a more stressful environment for carers, and that of course translates then into the behaviours often of people who are living with dementia, who maybe sometimes don't understand exactly the full context as to what's going on. So it has been a really difficult time for people living with dementia. With regards to research, we have our research projects set up. We have quite a fortunate system here in that we have a separate entrance into our older person services. So we're able to reassure people that they're not having to come through the main hospital. And I think it's about trying to make the environment as safe as possible for people living with dementia, and then try to deliver those research opportunities as much as there is a massive appetite from the point of view of people living with dementia who wanting to participate in research, and that hasn't declined. Of course, you have to balance up the risks though with regards coming in and out of hospital. So we've if you like, we dial down our research activity when we're up at level 5 and dial it back up again once this is over.
I know Alzheimer's Europe had a position paper there recently that they published on the impact of COVID on research. So if anyone wants to have a look at that, DRNI supported that position paper that they produced. So I'm sure there's a lot of challenges in relation to access to participants and things like that. Just very practical.
There is, but dementia research, though, has always been very challenging. By its nature, it's not been terribly well funded, and it's often the group that we're dealing with and trying to support are quite a vulnerable group. So it's a challenging area for research. So we're used to actually coming up with solutions. We certainly need better funding for research. I think one of the things that Ireland has a great opportunity to link different clinical specialists and scientists, because we're just around the perfect size for trying to do it, and I think DRNI gives a great opportunity to have us collaborate better, and I think I think there's more solutions in us working together than us trying to actually work apart and drive on apart. And my approach would certainly be that the more people we have putting their shoulder to this wheel, the better the quality of research, and the easier it will be to develop research funding programs.
Yeah. So another question coming in: is there any plan to link memory clinics nationally to have a standard, as standards still differ greatly from area to area in the country?
So, I mean, I think everybody would aspire towards doing it. The difficulty is if you take the amount of resource that we have working in our memory clinic isn't available. So many people are doing memory on top of their other posts, and there aren't people with protected time working in their memory services. So it's hard to expect a memory clinic that is trying to keep up with the need to diagnose people and just has a clinician able to give a half a day a week to the memory clinic, and maybe doesn't have a nurse, doesn't have a neuropsychologist, doesn't have certainly a speech and language therapist or occupational therapist. It's hard to standardize across that, and let's say a memory service like ourselves or James's or other larger services. So I think the NDO's approach would certainly have been about trying to maybe have hubs whereby you can have those more, if you like, those people who need more detailed assessment, that you enable them to be able to provide that, but also support people who are maybe not support people who are going to be giving the more, if you like, straightforward diagnoses. I think the most important piece that we need to actually work on is our post-diagnostic supports and how we enhance post-diagnostic supports. Understandably, because we still have so many people living with dementia who haven't received a diagnosis, there's a big focus on how we should enhance that and improve that. By the same token, in making that diagnostic piece only really has impact when you have appropriate post-diagnostic supports, and you try and do that. And we've certainly gotten better at that.
Okay, and that leads into the next question actually, in terms of people going undiagnosed. So from initial referral to diagnosis takes 4 months. However, this obviously depends on an individual being referred. Do you think that individuals with young onset dementia may go undiagnosed due to non-referral from their GPs?
So I think the short answer is yes. I think if GPs are working near services, near memory clinics, they have a very low threshold for referring. So I would see an awful lot of younger people who don't have any, who don't have dementia. And then I would also get those younger people who do have dementia. And I would be very worried if I wasn't seeing younger people who don't have dementia, because it would mean that the bar was set too high. I think unfortunately though, there's very few, GPs don't have access often to services or aren't aware of where to send people to it. And for many years, James's was probably the only centre that they were, the Myra Clinic in James's was the only centre that they would have been aware of. So I think it comes back to is certainly a little bit of the last question, whereby we do need to have a geographic spread of centres that are able to do younger persons, atypical, diagnosis piece. And and the National Dementia Office, I know, are working very, they're one of their key, I don't want to speak on their behalf, but certainly one of their key focuses is on trying to develop that national equity whereby people can get into it. So I think GPs will refer people on when they have people to somewhere to refer them to. But if you don't have anywhere to refer to, well, then it's probably better keep your head down and wait until somebody has advanced symptoms. And I think many of our younger people who are developing dementia, it's quite advanced stages when we see them.
Okay, great, thanks. So next question is, what sort of biobanks are available to researchers in Ireland to access samples, example plasma, CSF, along with diagnostic information, prodromal versus AD, etc., for biomarker research?
Yeah, so there isn't, because to be honest, we haven't actually linked our scientists and our clinicians. And that's a prerequisite of setting up a biobank, in that I can't, as a clinician, just aimlessly bank CSF and plasma with an ethics committee now. For the last few years, that's been the case. So for me to prospectively try and bank it's important for me to have a research question. So what I would say to any scientists who would like us to establish a biobank, most clinicians are very keen to do so. Some have small small biobanks or biobanks that are related to other research projects that they would have done. But from the point of view of a national biobank or a national thing, that's going to take quite a collaborative effort. And biobanks are they're very complex, and the regulations around them now are quite complex. So for scientists who want to get into biobanks and who want to get to human samples, I think it's important that those scientists are coming forward to clinicians now to present them with what are those questions they want to ask, what are the samples they need, how is it they want those samples prepared. For example, my priority is about seeing and managing the people within the clinic. It's not about giving, if you like, the nurse using her time to spin down bloods or to freeze bloods or to do CSF. We do that in the context of our clinical trials that we would be doing, but it's focused on that, around that clinical trial. So if it's going to be a more generic banking scenario, well then actually I think the important step is that scientists are reaching out and saying, what are the samples they want, what's the purpose, and how would they like them to be done, and what's the relationship going to be then with the clinicians on site.
Okay, thanks. So we've got quite a few questions coming in. You mentioned research opportunities focusing on carer education and training. Are there specific challenges or apparent gaps in this area of practice?
So, so there are some carer education and training programs, and I think what's happened is they've often been opportunistic, and they've grown, they've sprouted up and then they've gone down. We were for a number of years, we were doing one with the Alzheimer's Society, who have a carers education and training program, and we were working with them. And over the last wee while, we're kind of breaking out to do our kind of our own version, looking at that integrated model, just because I think it's important that they're local, and that you're able to give local context to these education and training programs. I think the whole area of diagnosis and management and understanding of Alzheimer's disease in particular, but all other dementia subtypes as well, has advanced quite a bit over the last 5 years. And I think the necessity is that those carers, carers now want to understand exactly why it is what's going on is going on. And actually, when you're able to explain the reasons underlying some of the behaviors, it becomes in its own right, it is much more manageable. So I think how we structure them, how we manage face-to-face versus online delivery versus what that information content is. What are the questions? I think there's a huge amount as to how we get peer support, because a lot of our programs at the moment are delivered by maybe clinicians or nurses or other specialists who are working with dementia, as opposed to, let's say, other conditions where there would be more peer support. So I think working with the Alzheimer's Society, working with the Parkinson's Disease Society and other groups, working with the ID, Intellectual Disability Services and their advocacy groups, I think there is still quite a lot to be done with regards having accessible carers education support groups. Most people who are looking after somebody with a diagnosis of dementia that I would still see don't understand what it is the diagnosis is.
Okay. So a comment in relation to that is a new patient aged 89 referred in July 2020, due to be seen February 2021 at Memory Clinic, that runs one afternoon a month. Stressful for clinicians in the community who are trying to get services and are seeing the lived experience of families. That's just a kind of the reality on the ground kind of thing.
No, and I think that's why you have to be very, so when we talk about standardizing across different memory clinics and different memory services and things like that, I think that's where you have to be, if you're, so there is heroic being done in many areas where people are trying to maintain, diagnostic and support services for people living with dementia without much resource at all. Dementia services haven't been resourced from a clinical perspective as well as they should have been, and there hasn't, a lot of that resource then has it kind of falls in around kind of, you know, very bespoke projects rather than it all being interlinked. I think what we've tried to do in Tallaght, which has worked, is so we were evolving an integrated care team and an integrated care team for older persons, and we looked at how we could harmonize that with the, you know, the co-development of our memory services. And similarly, we were kind of we were looking at our older persons, Jerry's geriatric services. 80% of the referrals were for memory, so we were kind of going, well, actually, are we really doing that 80% a service by trying to mix it in with 20% that we're detracting from provision of that? And that's why we lifted it out. So, you know, that was where we started with the specialist memory service, and it's taken about 5 years to build it to what it looks like now. And I suppose over the next 5 years, we certainly be looking to bring it on again.
Yeah, okay, great. How many people in Ireland going through a diagnosis for dementia have an MRI scan? And then there's another part of the question, but I might ask you to answer that one first.
Yeah, so I think it depends on the context. So let's say if it comes back to, you know, where we would do an MRI scan is where we're suspicious of it being, you know, so younger people, we would always look to do an MRI scan. You know, access to doing MRI scans is limited. So if the person has private health insurance, I would often try and do it, and you know, I would through that avenue rather than putting them on the hospital waiting list. So younger people, people with atypical presentations, or people who I suspect have a vascular burden. So in other words, people who I suspect may have had strokes. It's much easier. It's easier to see and quantify on an MRI scan than on a CT scan. I suspect it's probably in around 1 in 5 people will have an MRI scan. You know, I think if you go to a neurologist, you're probably more likely to be getting an MRI than if you're going to a geriatrician or old age psychiatrist. You know, by the same token, what I would say is most of our modern CT scans from are much improved on the older ones, and actually from a structural imaging point of view actually give us very good information that we would have traditionally have leaned to for an MRI scan. So actually modern day CT scans are actually much better than they used to be. So we still get a good bit of information out of CT scans.
Okay, great. And the next part of that question then is, how many will be able to avail of PET scans, and will Tau PET be introduced?
Yeah, so I mean, I think, yeah, good questions. So I think there's no reimbursement piece sorted out for the AMI PET scans. So I don't know is the answer with regards how accessible it's going to be. I think it'll be accessible from a research perspective, and clinicians, you know, people, I think, you know, clinically it'll be available, but possibly not reimbursed in that first while. I think from the point of view of amyloid PET scans, the key decision is going to be around aducanumab, the treatment, which the FDA are doing a meeting on in November and hopefully giving a definitive judgment on by March. And aducanumab will be the first disease-modifying agent for Alzheimer's disease, and it's an anti-amyloid agent. And I think, you know, if the FDA approve it in March, it'll be the first approved treatment since 2001 with memantine. So I think that's really where we're going to see the pressure coming on for, you know, the greater access for amyloid PET imaging, because to be honest, we've set up a whole service around how we do CSF biomarkers. It's not feasible in most sites to do it as we do it. You know, so I think, you know, there will be greater potential. But then PET scans, there's only about 6 or 7 PET scans in the country. So, you know, that will be a limiting factor. The expense of the scans, you know, they're probably, most countries are in around €2,000 to do. You know, and we're going to have to develop and build the radiological expertise in reading those scans. With regards to Tau scans, there's no doubt there's much better information in doing combined amyloid PET and Tau scans. And I would hope that the ability to do Tau imaging will come online quite quickly now. It's taken several years for the company to get licensed to do amyloid PET scans. The HPRA process has taken, you know, quite a number of years to work through, because it was the first, if you like, of its kind. What we would hope is now that they've worked through that process, that it will be easier to kind of do other types. It shouldn't be as difficult to, let's say, superimpose things like Tau imaging. Yeah, but the person who's asking the question is absolutely spot on. I think it's combined amyloid and Tau imaging is really one of those key enablers for the future. And Tau is quite exciting from the point of view of its ability to support the diagnosis of non-Alzheimer's dementia subtypes as well.
Right. And there's just one last part to that question, and it is the last question at the moment. What are your opinions on the new tau blood diagnostic?
So I mean, there's several blood tests that are kind of coming through. I mean, I think it's where I would see these blood tests fitting in is that they will probably be a gateway into more advanced testing. So certainly there's 2 or 3 papers now that have come out over the last number of months, which have all been very consistent. They've all been looking though at very discrete populations. So they've all been looking at very well phenotyped populations. They haven't been looking at general memory clinic populations, or not to mention the general population. So I think that's the cautionary bit about them, is that these are blood tests that have really only been trialed and sampled on very well phenotyped and selected populations. And we're going to have to see how they goes. Where I would see blood tests fitting in though is that where people have, they're far less expensive, they're far less invasive, and as part of that screening process that people may be able to go through. So if you were to do the blood test and the blood test was negative, well then it wouldn't make much sense to be probably doing an amyloid PET test. Whereas if you were doing the blood test and the blood test suggested that there may be amyloid, well then actually confirming that with an amyloid scan is probably far more merited. So I would see them operating perhaps on the basis of a means of selecting out people who may be more suitable to have more detailed investigations rather than as definitive diagnostic tests.
Okay, that's great. So that is all the questions. So thanks everybody for all those great questions. And I know we've run over a bit in time, but I suppose it shows the level of interest in this particular topic. And thanks very much, Sean, for your time this morning. That was really interesting. I think like a lot of these sessions, we often learn as much from the Q&A session as we do from the presentation. So I think both were equally really interesting. Just to reiterate, if people want to know more about the network, our website address is dementianetwork.ie, and you'll see on the homepage that there's a forum on next Wednesday, 2 to 3:30 on post-diagnostic support. So if anyone wants to register for that, the details are on our homepage. We also have a Twitter account, DRNI-RE, DRNI-RE, yeah. And as Sean mentioned earlier, we are particularly interested in linking, I suppose, scientists with clinicians. So if there's anyone who's been on the call or anyone you know of who wants to link in with clinical sites, you can come through to myself if you want in terms of coordinating that. I'll sign off and say thanks again to everybody for joining us today, and thanks to Sean, and have a good day.
That's all. Okay.